Right, so now we're moving on to the female sexual anatomy. If you note on my classes, there is a Word document that has a lot of notes about these structures we're going to talk about, as well as chapter 5 in your book. How we're going to look at this is keeping with the last recording, talking about the journey of sperm, the structures that Seymour, the sperm, are going to come into contact with as they go through the female external and then internal anatomy. So let me get this over here. All right. So what you want to do is follow along with this, and like I said, there's that Word document with some more notes. So I'm going to start with the female external genitalia, and that's essentially everything on this slide. What we're looking at here is a view. I guess the best way to put it would be if a woman is in stirrups in a doctor's office. You would have the view of the healthcare provider, the doctor or nurse practitioner, for example. So what we're looking at, the top of the screen is the anterior or the front view, and the bottom of the screen is the back or the posterior view. So we're going to go through these structures. And the one structure that's not present on here that I want to note, it's on your matching sheet and it's also on the Word document, is the hymen. The hymen is where we're going to start. So the hymen is essentially a thin membrane that covers the opening of the vagina, and it has really more cultural significance than biological significance. A lot of cultures place an importance on the presence of the hymen to equal purity or virginity of a female. It is a membrane. It is filled with blood vessels, and upon rupture or tearing of the hymen, there is commonly a little spotting, or maybe a little bit more than spotting, of blood to signify the breaking of the hymen. Now, of course, going back to the cultures, especially more ancient or traditional cultures, that presence of the bleeding from this area signifies the loss of the virginity or maybe a loss of purity. There's cultures that used to hang bedding, the bedding from the marital bed the morning after the wedding, to show, hey, there was blood on here, she was a virgin, that sort of thing. Although it's also interesting to note that just like today, there's nothing new under the sun, and there were situations where the woman maybe didn't have a hymen for one reason or the other. That didn't mean that she wasn't a virgin, but the hymen broke through other situations, through sports or something like that, and they had to go and find blood somewhere else from another source to still be able to show those marital sheets. So like I said, it's got a lot of cultural significance more than it really does biological. Every hymen's a little different. Some women have thicker hymens, some have thinner. The thicker it is, the more difficult it's going to be to break and the more painful intercourse can be. It can often be a procedure that has to be done as in like an outpatient. When we watch Kinsey, which is the movie assignment, the viewing assignment for Unit 3, there is Mrs. Kinsey has a situation where she has an abnormally thick hymen, and so it just needs to be removed by a healthcare provider. Not very invasive, outpatient type procedure. So that's a little note about the hymen. The mons pubis is the next structure that I want to look at, and it literally means a mound of flesh over the pubic bone. It serves functionality wise, it's a form of protection to protect the internal female anatomy. It also has more cultural significance when we think about pubic hair and how the norms, the cultural norms, have changed over time and vary from culture to culture. In our culture, the younger generations have different expectations than older generations as far as to shave, to wax, to bedazzle, whatever sort of landscaping you want to do there. It is really a personal preference. Some women find that it feels, sexual activity feels better. They're more sensitive if there's hair present. Some women find the opposite is true. So it's really a personal preference to have hair, to not have hair, to what extent to have hair. However, if you are going to remove hair to any extent, healthcare providers strongly advise against waxing, because what happens during the removal of hair via waxing is, yes, they're ripping out the hair, but they're also deadening nerve endings that are around those hair follicles. And so that will actually lead to a decrease of sensation, which I don't think anybody wants. So your best bet would be, if you have the money, it would be like electrolysis, a laser sort of removal. If you don't have that kind of money, at least shaving would be more recommended than waxing. So that's just a note about the mons pubis. Moving on from the mons pubis, we have the clitoris. And the clitoris was mentioned in the male video, that it's the female counterpart to the penis. It has the corpus cavernosa. I'll put a CC here for corpus cavernosa so you can remember that the clitoris has that spongy erectile tissue. It becomes erect upon sexual excitement, just like the penis does in males. It is the most sensitive part of the human body. I had mentioned in the male video that the penis is the most sensitive part of the male body, which is true. The clitoris is even more sensitive than that when we look at the amount of nerve endings per surface area ratio. So it is very, very highly sensitive, and we will make note of that later on when we look at sexual arousal and response, that during sexual arousal and response, it almost looks like the clitoris is retracted a little bit. In the second phase of the process, which is after excitement, which you could infer, oh, maybe she's not excited anymore, that sort of thing, which isn't true. It could be a protective mechanism. The labias will puffen up even more, and the prepuce can kind of fold over even more. The prepuce is kind of the hood, and so that, again, protective mechanism perhaps, just because it is so sensitive and so highly innervated. The size of the clitoris, it's very similar to the size of a penis. It varies from woman to woman. Some women have longer or wider in diameter clitoris. Some are shorter. It really, all that's normal and healthy and okay. Obviously, there are certain conditions that will present with an abnormally large clitoris that has medical implications, the same for like micropenis in males. But when we're looking at just the span of the spectrum of sizes, there's a lot of variety, and it's most of the time normal, healthy, no medical complications or issues with that. Same with the labias, the minora and majora. The look is going to vary from woman to woman, and that's just the variety of life. I think oftentimes we put certain social images in our mind of what these structures are supposed to look like. Porn definitely exemplifies these very narrow, finite views of what these things are supposed to look like. The same with male anatomy and penis size and all of that. Same thing with breast size and shape. And that is just, again, looking at the societal pressures and views that really don't have any link to what's biologically healthy. So that's the clitoris. The prepuce is often referred to as the hood. It is the tissue that kind of goes around and goes over, kind of hoods over the clitoris, and this is primarily a protective mechanism because of the sensitivity of the clitoris. Some women can choose to have the prepuce pierced. It's piercing that some women will get to maybe aid in sensation. It's all good as long as you're going to a reputable place and making sure that you're keeping up on your hygiene in that area, because it's certainly not a place that you want to have an infection. It can be very, very painful because of the nerve endings there. When we look at, sexual activities, different types of sexual activities, and in our culture, we put this male, female, penile, vaginal intercourse as the status quo. And one of the things that I want to try to break down in this class is that that can be one means in which people have sexual activity, but it's certainly not the only, and sometimes maybe not even the most pleasurable, especially for women. And the reason why is you have to look at where the penis will go, or anything that's going to be penetrated, whether it's a toy or a penis or a mouth or a finger. If we're focusing on the vagina is way down here. Let me get my highlighter here. The vagina is way down here. The clitoris is way up here. That's quite a distance, right? So oftentimes, if a woman isn't able to have an orgasm by that status quo of penile vaginal intercourse, they will start to think maybe there's something wrong with them. They're not able to have one, or maybe their partner's just not able to satisfy them. Well, most of the time that's not the case. And so this goes to support the notion of masturbation, communicating with your partner. You first need to know what feels good to you before you can negotiate with your partner the types of activities that you're comfortable doing and what types of activities feel good and don't feel good. So that self-discovery is really important. But just understanding the basic anatomy of the distance between those two structures. There's a lot of different types of orgasms that are talked about in various books that you can get at Barnes & Noble. I'll talk about the G-spot in a few minutes. But the majority of women have a clitoral orgasm. That's the most common way a woman orgasms, and that's across the board. The majority of women biologically can have a clitoral orgasm. But when you look at the distance between the clitoris and the vagina, it's not easily stimulated by penile vaginal intercourse. So that lends itself to what I like to refer to as a sexual toolbox. There's a lot of different tools you can use for any given time. So whether you're looking at different types of sexual activity, looking at oral sex or mutual masturbation, or you're looking at toys, there's a lot of different ways the clitoris can be stimulated. It doesn't always have to be through penile vaginal intercourse. So I want to break that wall down. Moving on, the labia majora and minora are here mostly for protection and to some extent lubrication. The majority of the lubrication that occurs upon sexual excitement is from the vagina, but there are glands in this area that are called Bartholin's glands, and those Bartholin's glands are responsible for some lubrication upon sexual excitement. Now, a note about lubrication. Women have the Bartholin's glands inside the labia minora, which are the inner lips. Then there's also the glands. Well, they're not really glands. It's a process called transudation, which fluid seeps through the walls of the vagina, aiding in more lubrication. Some women lubricate quite a bit, some not as much. That doesn't mean that they're not sexually turned on. Just like if a man doesn't get erect, that doesn't necessarily mean he's not turned on. There are a lot of shades of gray in the spectrum of sexual arousal and response. So it's the importance of lubrication. Obviously, it can help with the comfort level, decrease friction. But if a woman isn't secreting lubrication, it doesn't necessarily mean that there's something medically wrong. Certainly something to speak to your doctor about, but there is lube over the counter, KY jelly, any water-based lubricant that can serve as lubrication if there's not a lot being secreted either through the Bartholin's glands or through the vagina. The labia majora is more responsible for protection. The menorah also plays a role in sexual arousal and response. It's another highly sensitive area. It's not as sensitive as the clitoris, but it does play a role in sexual arousal and response and sexual satisfaction. Moving on to the vagina, but actually before I get to the vagina, I'm going to erase these little notes. I think we've got that concept of the distance between the vagina and the clitoris. We have the urethra. Some women don't realize that they have a urethral hole, and then they have the vagina hole, quote unquote. The urethra sits in between the clitoris and the vagina. Its role primarily is with the urinary system, but it can play a role in sexual arousal and response. But it's different than with males in that way, in that it doesn't share that role as far as ejaculation in males. It's got the dual role. That's not the same thing for women. So the vagina is, it always makes me chuckle because there's the age-old analogy that children make when they're learning about the differences between boys and girls, males and females, as boys have a penis and girls have a vagina. And again, that goes back to the misconception that penile vaginal intercourse is like the zenith and the only way to have any sort of sexual activity. It really is more appropriate to say boys have a penis, girls have a clitoris. But I think even though any of those words have social taboos, the clitoris might have more of a sexual kind of taboo than even the vagina. When you look at the entire female external genitalia, it's called the vulva. So all of this area is the vulva. That's the whole external genitalia. You could even argue vulva's a better counterpart to the penis than the vagina is. But then again, if you're looking at the male, the penis isn't the only external anatomy. We've got the scrotum and the testes and the epididymis and all those things that we learned about in the last PowerPoint movie. So the vagina is a potential space. It is not a gaping hole. It's a puckered space that can serve as a passageway for many things. Obviously, menstrual blood, for various types of sexual activity, for the birth of a child. It's a potential space, however. It is a shared body part between the external and the internal genitalia. It is only about 4.5 inches long from the opening, which you see here, to the cervix, which we're going to see on the next slide. And you think, wow, 4.5 inches. And how does that work with the various forms of penetration? Because many of them are longer than 4.5. Well, what happens upon sexual excitement and part of the sexual response is that the cervix, which is attached to the uterus, will tilt upwards, and that creates more space. So again, it's a potential space. It is very acidic, which we looked at in the last slide the last PowerPoint movie. It's a very acidic environment, very low pH, and that serves a protective role for the female. It also has a flora, bacterial, fungal flora. There's healthy bacteria that live there. There's also there's a healthy fungus that lives there, and we need to maintain this balance. Certain things can throw off the balance, though. Sometimes sex can throw off the balance. Taking antibiotics will throw off a balance because antibiotics are ingested to kill bacteria in the body, which works really great when you want to kill that nasty staph bacterium or whatever bacterium is making you sick. But there's a downside to taking antibiotics, and that's that it kills oftentimes many other bacteria in the body that we want to be there. For example, in the colon, or in females, the vagina. So that's why it's common when women take antibiotics, their bacteria count goes down, their fungal count goes up, throwing that off balance in the flora. They're more prone to yeast infections. So that's why women who are on antibiotics oftentimes will get a subsequent yeast infection because it throws off the flora. Um, the same thing if they're on an antifungal medication, especially more of a systemic one, a general one where they take orally and kind of goes and um, it affects the body very generally. It could throw off the fungal count in both the colon and the vagina in females, and that could lend itself to a bacterial infection because the fungal count's going down, the bacterial is going up. So that could lead to bacterial vaginosis, BV, or some other type of bacterial vaginal infection. So just speak with your healthcare provider whenever you get uh, prescribed an antibiotic or an antifungal. You can take a medicine that will help prevent that by maintaining the flora. Finally, a third thing that can throw off the flora is douching. Douches are still on the market. Honestly, I don't know why. Most sexual health educators will always poo-poo it because the research that's come out is not good. It throws off the flora to an extent where you could either get a bacterial or a fungal infection, so stay away from douching. It's not recommended really for anything. Within the vagina, there are some potential places for sexual satisfaction. And one of those places is the Grafenberg spot or the G spot. It is an anatomical spot. It's in the anterior part of the vagina. In some women, it's very sensitive and it can lead to an orgasm. In some women, it's not. So when we talk about the G spot, it is potentially there it's there as an anatomical spot, but it's a potential site for sexual arousal and response. So some women, if they hear, oh, there's this G spot, and that's like the zenith orgasm, and if I'm not having one, there's something wrong with me. That's not the case. It's sensitive in some women, it's not in others. It's different than the clitoris in that way. The clitoris is only there for sexual satisfaction, whereas the vagina has other roles. And so I just kind of wanted to make a note out of that. Within the vagina are Skene's glands. And Skene's glands are there and play a role in female ejaculation. Now, some of you might be familiar with female ejaculation, some of you may not. Women have the possibility, they're capable of having an ejaculation, but it isn't kind of like with the G spot. A lot of times the release from the Skene's glands goes along, kind of hand in hand with the G-spot orgasm. It's present in some women, it's not in others. There's a misconception that if she doesn't squirt, which is basically the release of fluid from the Skene's glands, and she didn't have an orgasm, and that's not the case. Clitoral orgasms are often silent. They're often the most common. So that just goes back to good old-fashioned communicating with your partner. You'll watch a video. One of the episodes of TLC that you're watching for this unit does highlight a woman who later in life started experiencing female ejaculation, and she was really freaked out when it first happened because she thought it was urine. She thought maybe her bladder was leaking, and that's not the case. Skene's glands fluid is primarily water. It's not urine. It's much different than the male ejaculate, of course. It's not composed of all those things that we looked at in the last PowerPoint movie. Can be present, doesn't have to be, and either is okay. So reading along with the Word document, that covers this external slide. So now what I'm going to do is erase this. Let me get my large eraser out, and we'll move on to the internal anatomy. Thank you for bearing with me with this new technology. I'm learning the ropes here, and that's what this icon over on the lower right hand side of the screen is. It's the company of this software that I'm using. All right, so let's advance to the next slide. Here is the female internal anatomy, And these are going along with pages 78 through 81 in your textbook, if you're following along. We're looking at this head on, so you can see down here the boxed off view of the female. I like to think that this looks like Bullwinkle, the old Moose cartoon, or Domino's Pizza used to have a character called the Noid. It looks kind of like the Noid's head. But this is essentially the internal anatomy. Like I said in the previous slide, that the vagina is both an internal and an external anatomy structure, and you can see that's true here as well. And so we've got the latter 2/3 or so of the vagina. The vagina then goes dead end, and this is where we get to Seymour, going back to Seymour, the sperm. The sperm at this point had been traveling through, and then it has to get up to the fallopian tube to meet Olivia, because that's where fertilization occurs. The cervix has a lot of importance. It, as you can see, it's this part right here, kind of a dome-shaped structure. And then there's a potential space right here in the middle. And this potential space is called the cervical os. So if we took the cervix and looked at it from a more head-on view, in some textbooks, they say it resembles a donut, which would imply that the os is a gaping hole. We know that's not true. It is actually a puckery or a potential space. This is the cervical os. The cervical os plays a lot of roles in conception as well as in contraception, so either promoting fertility or trying to prevent pregnancy. The os is often targeted in many barrier methods of contraception. So when we look at the female condom, we look at the diaphragm, the cervical cap, and the sponge, which we're going to look at in the contraceptive PowerPoint in this unit. They all work to cup around the cervix, and in particular the os, because it's the os that Seymour the sperm is going to, that's the window that Seymour the sperm is going to get through to be able to go further on into the female anatomy and hopefully meet Olivia in the fallopian tube. It is also a space where, depending on when the sexual activity occurred and when ejaculation occurred and when ovulation happens, sperm can actually hang out in the cervical os in this puckery space for up to a week. And that's the point that I have on your worksheet. It can serve as a sperm motel. So again, if you're trying to conceive, you might want to use this to your advantage. If you're not trying to conceive, you need to keep that in mind, that in tracking and being aware of your ovulation, if you're not using any form of contraception, including the withdrawal or the pull-out method, there can be live sperm that can then move on up at ovulation and fertilize the egg that's released at ovulation. So you want to keep that in mind. The other thing about the os, which we'll look at when we get to the menstrual cycle, is one of the telltale signs that a woman's ovulating is this thinning of cervical mucus. Throughout the month, the cervical mucus is relatively thick, which makes it almost impossible to be permeated through by the sperm. The sperm can't get through this thick mucus. It's not going to be able to move upward and onward in the female tract and won't be able to fertilize that egg. However, at ovulation, which is the only fertile time in a woman's monthly cycle, that mucus thins and makes it easy or easier for the sperm to permeate through and move on upward to maybe fertilize that egg. So that cervical mucus does play a role in that process. In reproductive examinations, pelvic examinations, the os is what's scraped. A swab is often taken just to check for any signs of abnormal cellular growth during a female exam. So that is another area of importance of the cervical os. When a woman is going into labor, about ready to give birth, whenever you hear that she's dilated so many centimeters, 5 centimeters up to 10 centimeters, it's the os. It's this structure right here that's actually dilated. So you need it dilated in order for the natural or the vaginal birth of a child. It's also dilated not to the extent in childbirth, but a couple of centimeters to allow the insertion of an IUD, which is the intrauterine device we're going to look at later on, but it is inserted up through the os and then is a T-shaped structure that is then implanted into the uterus. And we'll look at that a little bit later with contraception. Moving on, the cervix is technically part of the uterus, and the uterus is, let me get another color here, is this entire structure, the head of the noid, if you will. It is a muscular structure. It is made of smooth muscle, which contracts for various reasons. It certainly contracts when a woman is going into labor. That's responsible for the uterine contractions, which makes sense because the fetus is in here. And when a woman is having menstrual cramps, it is the contraction of the uterus. Essentially, menstrual cramps are a less intense form of labor contractions. So that's the contraction of the smooth muscle. There are 3 layers. There's the endometrium, which is the inner layer. There's the myometrium, which is the middle layer. I'm more concerned, however, with the endometrium, which is the innermost layer, because of its significance. It will either stay or go, depending on if fertilization occurred. If fertilization occurred, which occurs here in the fallopian tubes, the egg will roll down and implant itself into this layer of the uterus. It will implant into the endometrium. If that does not happen, let's take that away, this layer of the uterus will shed once a month. And it's actually part of the endometrium, only half of it's shedding once a month as per menstrual fluid. So it either stays or goes depending on if fertilization occurred. If there's anything else. There are procedures, new procedures now when a woman is typically older. She's done having children, if she has children at all. And it's not uncommon for women in their older years to experience abnormal bleeding, heavy cramping, and they are just like, I'm done with this. Let's, get this out of me. Back in the old school, they would remove the entire uterus, which is a partial hysterectomy, removing just this. There can be complete, which they remove everything. That's very invasive, we know now, and we now have the technology to where that's not always necessary. So there's procedures now that will actually go in through a laser or some type of non-invasive technology that'll just go in and scrape out the endometrium. Once the endometrium is gone, you're not going to have the bleeding problems with menstruation. You're not going to have menstruation commonly, not always. With some of the procedures, she can retain some sort of fertility, and then it might, prevent, cramping, the bleeding, and all that. So that's a common procedure. Moving on, we have the fallopian tubes, and their claim to fame is this is where fertilization occurs. This is where the fireworks happen between Seymour and Olivia. Whoops. That is the worst O in history. But this is where the fireworks happen. This is fertilization. The egg is released from the ovary about once a month, and it travels down the fallopian tube on her tract. And then if Seymour, the sperm, is there, that's when it happens. Ovulation typically lasts anywhere from 24 to 72 hours. And that's the only time in a month where the fertilization can happen. Ideally, what happens after fertilization, as I noted earlier, the fertilized egg rolls down and plants itself into the wall of the uterus. Occasionally, that doesn't happen, and you can have a tubal pregnancy, which can be very complicated, where it actually embeds in here. You can imagine this very narrow passageway wouldn't be very conducive to the fostering of a fetus. It's not like the pillow-like structure that occurs here in the uterus. But that's the fallopian tube. That's the one thing I want you to keep in mind. The ovaries here are the female gonads. They're the female counterpart to the testes in males. About once a month, they secrete their eggs, one egg at a time. A woman is actually born with all of the eggs she will ever need in her life. More, actually, eggs than she will ever actually use in her life. And a woman actually is born with about 1 million eggs. And in the course of her fertile lifetime, she usually only uses about 400. I was actually watching a TV program the other day, and there was a concern about the longer a woman waits to conceive, she's running the risk of using older eggs. And I had to chuckle because that's not the case. All of the woman's eggs are about the same age because she's born with them. And it's not until puberty, when the hormones start being secreted, that she's viable, that these eggs are viable to start being released and matured. But she is born with all of the eggs. So if a woman is 40 years old, her eggs are 40 years old. They mature one at a time, once a month during ovulation, but she's born with all of them. When we get to the hormone section, you'll be able to see that the ovaries and the eggs themselves even are responsible for secreting the primary two hormones, which are estrogen and progesterone in the female cycle. Okay, so that's all I wanted to say with that. And moving on, we have the old-fashioned lateral view. This is also in your book. Whoops. So just like with the male, we're looking at the side. To clarify, there won't be any diagrams on the exam, and the matching worksheet that's on my classes is what you'll want to look at for the quiz, the reproductive quiz, as well as exam 2. But this just gives you another view of the anatomy. I personally like the two views, the one of the external and then the frontal view of the internal, as opposed to this one. But it's there. I wanted to include it because it's included in the book. Okay. Finally, we have to move up above the waist and finish out this discussion with the breasts. In our society, we give the breasts a very dual role. They're very sexualized in the cultural context, and then they also serve a very biological role in both sexual arousal and response, as well as nourishment of a newborn. In many cultures, the first function on the slide, well, the first one also lends itself to female sexual satisfaction. So let me rephrase that. In other cultures, the idea of sexualizing breasts isn't the case. And in some cultures, breasts are just basically looked at as baby bottles on a woman's body. They're not sexualized. And in those cultures, they take public breastfeeding in a much different way. Their reaction to public breastfeeding isn't like what it is in the United States, because the United States has gives this dual perspective of breasts. You know, they're sexualized almost more so than they're seen to be used for providing nourishment. As far as the tissue itself is made of mostly fat, which is adipose tissue, and then there's some connective tissue as well. The areola is the only muscular portion. That's the portion that surrounds, that's the nipple area. That plays a role in sexual arousal and response, with the tightening of that muscle upon sexual arousal and response. Mammary glands, regardless of breast size, Every woman has about the same number. Every woman has about 30 to 40 total. So about 15 to 20 on each side with the mammary glands, regardless of fat. As far as breast size, it's mostly determined by your genetics and the amount of estrogen that a woman naturally secretes based on those genetics. Fat, gain or fat loss or having children can cause slight changes, but most of the time your breast size is predetermined genetically. So as I said, there's 15 to 20 mammary glands in each breast. They secrete milk as a reaction to the work of two hormones, which are also included in the hormone PowerPoint. Prolactin makes the milk, so you think lactose, which is milk. Oxytocin plays a role in the letdown reflex of milk once it's produced. And like I said, every woman has approximately the same glandular tissue despite breast size. The difference between male and female breasts, obviously male, the adipose, the size of their breast tissue varies from male to male, but the male breast tissue doesn't have the glandular tissue, the mammary glands, like females do. Again, you can see where the pec major muscle is, major chest muscle. This auxiliary tail here, actually use this one because it's a smaller. This is often a site of masses. So when doing a BSE, it's always important to go up in the axillary tail or the armpit as part of the BSE, because that is a common site. There's ligaments and glandular tissue. I'm not going to hold you responsible for really knowing that. On the worksheet, it's just noted how many glands a woman has, and again, this is despite breast size. So that closes out with the diagram there. And I've already mentioned this of what determines breast size. And we've already kind of noted how the dimensions of health, cultural, psychological, and really biological connect with breast size. It's a very common cosmetic procedure to have breast augmentation to either lift, increase, decrease size, and really that's more of a psychological and cultural factor than it is biological. Most breasts serve their biological functions as needed, regardless of size. And then like with the TSEs, this is just here as a personal health note. I won't have questions about how to do a BSE on the exam or on a quiz, but it's just the health educator in me to put these on here. The one thing to keep in mind with females, however, is you do have to pay careful attention to the time of the month. And the other thing, and just like with testes too, the important thing about these regular exams is, like with breasts, for example, breasts can be naturally lumpy. And most of the time, those lumps don't serve any major danger, don't present any major dangers. So it's all about the regular monthly checks to kind of discern between the lumps that are just part of your makeup, anatomical makeup, and don't pose a threat, to the ones that maybe weren't there a month or two ago and might be red flags. So if you don't do those exams regularly, you don't get a chance to know what your healthy tissue is and what those, harmless lumps are versus maybe more harmful lumps. So that's just a little public service announcement for BSEs. And that closes out the anatomy. Hopefully the tutorial helped a little bit go through some of the parts. And again, just refer to this, the Word document on My Classes, and then Chapter 5 in your textbook. And use that matching worksheet to prepare you for the quiz as well for the exam. And you'll be in good shape.